Hey, my name is Katrina Bird, or my patients call me Dr. Bird, and today we're going to learn about cephalosporins. So, if you haven't seen the video on penicillins, I suggest you watch it before watching this video. So, let's get started. All right, so today we're going to talk about cephalosporins. However, before we get started with that, let's just review how they work. So, if you've taken a look at the penicillin video before, this should look familiar. So the light blue is NAG, N-acetylglucosamine. The purple is NAM, N-acetylmuramic acid. These are the structures that make up the actual walls of the peptidoglycan. These green structure here are individual amino acids that come together in a straight line as well as cross-linking. This is your peptide bridge. This pretty much stabilizes your peptidoglycan layer. So this also should look familiar. You've probably never eaten a multi-layered cake that didn't have any icing in between or around it. Why? Because the icing stabilizes the multiple layers on the cake. Peptidoglycan works exactly the same way. Think of the actual cake layer as your NAG and NAM, and the icing in between as your peptide bridge. So if I want to destabilize the peptidoglycan layer, I'm going to basically mess with this peptide bridge or remove the icing in between the multi-layer cake. So in that case, as I slice the cake, and if it doesn't have any icing in between or icing around it, it becomes unstable. Same thing in regards to messing up the peptide bridge for peptidoglycan. So this is basically how penicillins and cephalosporins work. So let's go further into the mechanism of action. So first each bacteria has a penicillin binding site. So the antibiotic, in this case cephalosporin, will look for the penicillin binding site on the bacteria. So that's the first step. It looks for the penicillin binding site. This tells it which bacteria it can kill. The next thing it does, it inhibits transpeptidation and cross-linking. So basically, it gets rid of that peptide bridge in between the layers of the peptidoglycan, thus making the structure unstable. So how can we get resistance? So this is a structure of penicillin, not cephalosporins. I know we're talking about cephalosporins, but this is penicillin. I just want to highlight that this is the beta-lactam ring that we are talking about when you're calling penicillins and cephalosporins beta-lactam antibiotics. It's referring to this square structure here. And this is going to be the site of action of your beta-lactamase. And it likes to work there because breaking this bond and creating the resulting structure is more stable than its current state. All right, so a couple mechanisms of resistance is one, the bacteria changes its penicillin binding site. So basically when that happens, the antibody goes to see which type of bacteria it can kill, and it doesn't recognize anything because it can't recognize the changed penicillin binding site. And also, the bacteria produces beta-lactamase, which is an enzyme that breaks down a beta-lactam, which all cephalosporins and penicillins have. Notably, these are the two mechanisms of resistance for MRSA. So let's go deeper into cephalosporins. First generation, probably some of the more popular cephalosporins, and they should start to look familiar to you if you're prescribing these medications. All right. So let's talk a little bit about staph. So staph, specifically methicillin-sensitive Staphylococcus aureus, can cause all types of skin-related infections. One, it can cause boils, which is kind of a deeper, kind of pussy, kind of abscess. Cephalitis, which is more superficial infection, so forth and so on. Strep can also cause these types of infection. So when you're thinking about treating these kind of skin and soft tissue infections, please think about your first generation cephalosporins, which happen to be Cephalexin or Keflex, which is oral, and Cefazolin or Ancef, which is IV. A lot of the surgeons like to use Cefazolin before surgery and perioperatively because it gives you great gram positive, a little bit of gram negative coverage, and it has a long half-life. So they love to give a dose prior to them making their initial incision for surgery, and then give at least another dose after the procedure. So remember, it gives really, really good gram-positive coverage, but specific organisms I want you to think about is MSSA and strep in general, and it also gives you a little bit of gram-negative coverage. Next, let's talk about our second generation cephalosporins. So before we go into it, I want to talk a little bit about urinary tract infections. So in general, how people typically get urinary tract infections are bacteria from the GI tract, unfortunately, comes up into the urethra and into the bladder. So for women, we have short urethras. Basically, there's a short distance between our bladder and the outside world. So bacteria can easily go up into the bladder and cause a urinary tract infection or cystitis. For men, they typically don't get urinary tract infections as often because they have a penis and thus a long urethra. The reason why I'm talking about urinary tract infections is because these are going to be some of your primary antibiotics, our second generation cephalosporins that you're going to use to treat them. So typically you can use Cefixime and Cefdinir, which are oral, or Cefotetan and Cefoxitin, which are IV. Additionally, it can also treat intra-abdominal infections, and it has similar coverage, but extends or gives us a little bit more gram-negative coverage. So in general, we're going to be building on top of each of our cephalosporin the higher the generation. In general, so it's not absolute. So I'll tell you when we stop building. So let's move on to our third generation. So this is going to be Ceftriaxone. So this is just a structure, and again, it has that beta-lactam ring. So when you think about Ceftriaxone, remember it's going to cover MSSA, it's going to cover strep, it's going to give you gram-negative coverage. But the two infections I really want you to remember is one, pneumonia. So this is a chest radiograph, and it's showing you a middle lobe pneumonia. Pretty low bar, which is pretty significant, and this is what you typically see in a bacterial pneumonia. The other thing I want you to think about, I'm showing you the brain and the spinal cord because I wanted you to think about meningitis. So our third generation cephalosporins and higher are going to be the antibiotics that's going to get through our blood-brain barrier the best. So we want to make sure that, for example, someone has meningitis, we don't want to give them Cefazolin, for example, because that's not going to penetrate our blood-brain barrier. All right. So an acronym to remember what infection Ceftriaxone does not cover, because now I'm telling you it covers quite a few things. Please use the acronym LAME. So L stands for Listeria. So Ceftriaxone does not cover Listeria. This is why, for example, in young kids, when they come in with sepsis or meningitis, and when I say young kids, I'm thinking babies, we will add ampicillin to give us Listeria coverage. Additionally, we think about Listeria when we're thinking about our elderly person coming in with fever and altermentation. Again, you will add ampicillin, and there are other medications that will cover Listeria. Next, think about atypicals. So, for example, the one example I love is Mycoplasma. So Mycoplasma is a lovely bacteria that does not have a cell wall. So how did I tell you cephalosporins work? They act on the peptidoglycan, which is part of a cell wall. So if you don't have a cell wall, you're not going to be able to work against that bacteria. So Mycoplasma is a key. And that's also a key example. If you know where the antibiotics work, you will remember what they cover. Next, M stands for MRSA. And I've already kind of gone through why cephalosporins and penicillins don't cover MRSA. And last, enterococcus. I don't have any fancy things to remind you that enterococcus, like you can't use ceftriaxone for enterococcus, you just got to know it. There are two medications primarily used for enterococcus. One is ampicillin and one is vancomycin. All right, let's move on. Now, let's get to our fourth generation cephalosporins, which is Cefepime. I love Cefepime because it's our cephalosporin that gives us pseudomonal coverage. And it also will give you coverage against some multi-drug resistant gram-negative bacteria. It still gives you some gram-positive coverage too, so don't forget that. The one thing, I put this picture because you see these kind of curved rods and it's kind of pinkish to let you know that number one, Pseudomonas is a gram-negative rod, and two, that Cefepime covers Pseudomonas. Trying to give you some kind of visual clues and keys so you can, to help you remember these things. All right, so let's move on to our fifth generation cephalosporins. Before we go there, let's talk a little bit about infective endocarditis, and at the end it'll all make sense. So this is here to the left is a cross section of the heart, and what circle is the aortic valve? I can tell because this is a left ventricle, blood goes through the valve and into the aorta and subsequently to the rest of the body. So here's a close-up of what the valve should look like. Very clean. However, when bacteria infects the valve, now it's kind of rugged looking and you have these small bacteria here, which is bad. There are multiple types of bacteria that can cause infective endocarditis, one of them being MRSA. And this is what I want you to think about when you're thinking about our fifth generation cephalosporin, which happens to be Ceftaroline. So it covers quite a few things. This is an antibiotic that we don't use first line. And this is why. Number one, it's not available in all places, and two, we like to reserve this because it treats our most resistant bacteria. So let's talk about a few of those. One, it covers MRSA, like I just already explained. Two, it covers multi-drug resistant strep pneumo. So unfortunately, if someone has been exposed to a lot of antibiotics or been hospitalized, they may get this type of infection. So remember, Streptococcus pneumoniae is the full name. That is our most common cause of meningitis, bacterial meningitis, as well as bacterial pneumonia. Next, it can also cover VISA. What is this? You're probably like, I haven't heard about this. It is vancomycin intermediate Staphylococcus aureus. So it's not quite resistant to vancomycin, but it's starting to develop some resistance. So in this case, it's not giving vancomycin, and giving ceftaroline may be a good option for your patient. Next, it covers anaerobes, so that's above and below the diaphragm anaerobes. So another medication choice that you may consider depending on the clinical scenario. And lastly, and I feel like this is one of the most important things. So this medication covers the most resistant Staph aureus. So it covers vancomycin resistant Staph aureus, linezolid resistant Staph aureus, and daptomycin resistant Staph aureus. So as we know, the more antibiotics, the more an antibiotic is in the community, the more it's used to treat various infections, the higher the risk of developing resistance. So this is an antibiotic we want to kind of keep in our back pocket to treat our nastier infections. Okay, so then that brings us to our last topic, which are special cephalosporin combos. The first one we're going to talk about is Zerbaxa, or Ceftolozane-tazobactam. This medication covers most aerobic gram-negative bacteria, but remember, it covers Pseudomonas. So it will cover probably a little bit more of your more resistant Pseudomonas. So as I stated earlier, Cefepime is our other antibiotic, our other cephalosporin that covers Pseudomonas. However, what if you're Cefepime resistant? What are you going to do? So one other option is using Zerbaxa. It gives you a little tiny bit of strep coverage. However, look what it misses. It misses all staph. I'm going to say it again because it's important. It misses all staph and most strep and CRE. So that's carbapenem resistant enterobacteriaceae. So let's just go back. In regards to the staph, If you're using Zerbaxa to treat a resistant pseudomonal infection and you have a staph present, for example, if you're treating a complicated intra-abdominal abscesses, multiple intra-abdominal abscesses, and one of the bacteria you grow out is Pseudomonas, but they also have MSSA, well, you're gonna need to add an additional antibiotic to make sure you're treating that staph infection. Okay? The other thing is if our CRE, our carbapenem resistant enterobacteriaceae, is super resistant, you've probably heard it on the news, it's that superbug. Zerbaxa is not the antibiotic you want to give for that. But let's talk about one you possibly could give. Here comes Avycaz. So this is Ceftazidime-avibactam. And you're like, oh my God, what's the difference between Zerbaxa and Avycaz? Like, I can't remember. So remember, I'm telling you that it covers CRE. So the way I kind of remember is the A covers CRE. So Avycaz, or the antibiotic with avibactam, is what's going to cover CRE. It also covers Pseudomonas, but let's see what it misses. It misses all gram-positive bacteria, like nothing. At least you got a little bit of strep with the Zerbaxa, but you don't get anything with the Avycaz. So you have to remember that. Also, it's going to miss anaerobes like Bacteroides fragilis, and it's going to miss some CREs with a metallobeta-lactamase that produces metallobeta-lactamases. So there are multiple mechanisms in which a bacteria can become a CRE. And producing this metallobeta-lactamase is one of them. So this is an antibiotic that we are kind of reserving for our most resistant infection. All right, in regards to dosing, please check out my IG account, dr_kbird. The only thing that's missing is I don't have the second generation cephalosporins listed that I listed here. So I'll put that up later.